Hi everybody, it's Dr. Sloan, and we're going to talk about antibiotics and antituberculars. We're not going to really talk a lot about fungus protozoa. That's a separate recording. Okay, let's get started. So here's our key terms. Pathogenicity. This is really the ability of an organism to cause infection by overcoming a body's defenses. So if we say that something is highly pathogenic, that means that it's very easy for that bug to overcome the body's defenses and make us sick. Virulence is the ability to produce disease despite very small numbers of organisms. A good example of this is measles, which is actually a virus, but measles just takes a few particles in order to cause the infection. Bactericidal means that cidal, like suicidal, it kills bacteria. And bacteriostatic means just what it says. Static or stasis means that it slows bacterial growth. And if you were ever going to read a chapter of your pharmacology book, this is the one that I would read. I think it's easy to understand, has some great illustrations in it to help you with the antibiotics. Okay, bacterial versus human cells. Why are we going all the way back to this? You already learned this in micro and A&P, except that it's very relevant to a discussion about antibiotics. Is why do antibiotics kill bacteria and not human cells? Well, it's because they're different, right? We know that bacteria have a cell wall. They have no nucleus, no organelles. They come in many different shapes. Remember Gram-cocci or bacilli. They have a tail, whereas human cells are much more highly organized. There's a cell membrane, there's a nucleus present, highly structured organelles. They're different, and that's why antibiotics don't kill our human cells. They kill bacteria. So again, here's just a actual illustration highlighting these points. And again, this is a bacteria. And this is a human cell. So human cells don't have cell walls, they have cell membranes. That's why so many things go across our cell membranes into our cells, like glucose and other things. So anyway, just a little point of reference there. So bacteria characteristics, and this should all be reviewed from micro, okay? There's ways that we can kind of classify bacteria based on I'm trying to think of the word, based on basically a naming structure. So we can look at gram stain. Are they positive? Are they negative? Do they gram stain positively? Do they gram stain negatively? That's one way to tell what the bacteria is. And then are they anaerobic or aerobic, right? Do they need oxygen or do they grow best without oxygen? And then shape, and that actually can be seen right under the microscope. So these are things that, especially gram stain and shape, are things that we can learn about a bacteria very quickly if we can see it under the microscope. Okay, acquired resistance. One thing we need to talk about, and this is really an important concept, so I hope that you will avail yourself of the great TED Talk that I have posted in your pre-class activities and the two really brief little Khan Academy modules on antibiotics, because I can't do as good of a job here as they can. But resistance is a huge issue with antibiotics, and we need to know that as nurses because it affects how we teach patients, what we teach patients, and how we treat our patients with antibiotics. So bacteria can replicate really fast, which means that it's prone to frequent errors or mutations. And these mutations can be very beneficial to the bug itself because they can learn about the environment they're in and become resistant to things that are trying to kill them, which allows the bacteria to survive longer and possibly grow faster than other cells, okay? Now, antibiotics don't create the mutation, but they create an environment in which mutation is more likely to occur. By killing the surrounding susceptible cells, okay, so killing, the bacteria and killing those cells, that's great. But if we don't do a good job of killing all the cells and we leave some behind, i.e., we don't finish our antibiotics, then that allows the mutated cells left behind to grow without competition because you've killed off some of the healthy bacteria cells. So now we're going to have some of the mutated cells take hold. Okay, so again, unwarranted use of antibiotics allows the unrestricted growth of drug-resistant organisms. And many of these organisms are part of our normal flora, right? So we have to be really careful when we take antibiotics. For instance, a number of people will go to Mexico and purchase antibiotics and basically dose themselves. Patients also go to the doctor. They don't feel good. They believe that antibiotics are the key. You have a mom with a sick kid, and by gosh, she's not leaving until you give her antibiotics. That's what we would consider unwarranted use of antibiotics. Treating somebody with antibiotics when treatment really is not indicated. And there are a number of organizations that have guidelines out for which particular infections should be treated and with what antibiotics. So again, if we kill off our normal flora, then we're upsetting the balance, the bacterial balance in our body, and that leaves us more susceptible to infection. Now, nosocomial infections, y'all should know about these because we're trying everything in our power to prevent these when we're in the hospital by washing our hands, by wearing gloves, by using hand sanitizer in between all patients, in between all procedures. But unfortunately, nosocomial infections are ones that are acquired by the patient in the healthcare setting. So they didn't have it when they came in, but they have it when they leave, or they have it and have to be treated before they can leave. And good examples of these are MRSA or VRE, which is MRSA is methicillin-resistant Staph aureus, and VRE is vancomycin-resistant Enterococcus. So you need to take all of the prescribed course of treatment when you're given antibiotics, because if we don't, we stop halfway through, we're feeling better. Now those bacteria that have mutated, they don't have any competition because you've wiped out all the susceptible ones. They can start to replicate. Whereas if we take all of our antibiotics, then we have fewer cells to mutate and to take over growth. So antibiotic prophylaxis, that's another concept that you need to think about. And sometimes antibiotic prophylaxis can lead to acquired resistance, okay? So I think about people who maybe have a heart valve, had a heart valve or a heart procedure of some sort. When they go in for dental work, they end up having to take antibiotics because we know that when we jiggle around teeth and we scrape and scratch and do those kinds of things with teeth and gums, we're going to loosen bacteria, which is going to go into the bloodstream. That bacteria has an excellent opportunity to seed in the heart, especially around wherever the surgery occurred. Because remember, we've changed the nice smooth surface of that particular tissue. And so that's great. We want to put people on antibiotic prophylaxis. But again, are we sensitizing regular bacteria to this antibiotic and thereby creating resistance? So how do we know which antibiotic to use? This is always fascinating to me as a nurse and wanting to know which drugs we treat what with. So broad spectrum versus narrow spectrum. And I think I mentioned this in my last lecture when we were talking about oncology, but broad spectrum antibiotics, this is what I was saying is the machine gun of antibiotics. It just sort of sprays It kills a lot of different kinds of bacteria. And that's fine for a little while. But again, if you think about our normal flora that we have inside, and we have a huge, bacterial, we have a huge biome in there. If you're doing broad spectrum antibiotics for a while, you're going to wipe out a lot of that biome. Versus narrow spectrum is effective against only one or a few different species of bacteria. And that's really what we want to do when we treat someone with antibiotics, is we want to be as specific as possible. And it really depends on the patient and what's going on. But again, we need to know the difference between broad and narrow. Now, if you think about it, what type of antibiotic would be given if the source of infection is unknown? Like our febrile neutropenia patient who comes in, well, probably we're going to give them a broad spectrum antibiotic because we don't know what the offending organism is. And until we do, we don't want anything to kill our patient. So for the 3 to 5 days that we're going to wait for culture results, we are going to give this patient a broad spectrum antibiotic. We may even give them 2. But then when the culture and sensitivity comes back, then we'll be able to know which antibiotic they should be on, and they'll be changed over to that specific antibiotic. Now, culture and sensitivity, we talked about this as well previously, but when should cultures be taken? They should always be taken before the first dose of antibiotics. Because again, once you have antibiotics on board, it's going to kill some of that bacteria. And if you draw a culture after administering antibiotics, you may have cell death and not have anything show up on your culture. This takes 3 to 5 days. So 3 to 5 days is how long it takes to get back culture and sensitivity. So you're not going to get blood culture results the same afternoon if you drew them in the morning. And that's something that you'll need to pass on in your report, is that cultures were drawn a day ago, cultures were drawn this morning, cultures were drawn 3 days ago, so that the nurse taking over for the patient knows, wow, I can go start looking for those results, or I'm probably not going to expect to see those yet. So here's an example of a petri dish in which there is a bacteria growing. And if you look here, a drug like this, whatever is on this little wafer, is doing a really good job of cell kill, right? But if you look down here at this particular bacteria, a particular wafer and particular drug, whatever it is, bacteria aren't too bugged by it, so to speak. So same over here. This one has a little bit of cell kill, but not much. We want really good, sharp cell kill. So this would probably be the type of antibiotic that would be recommended, depending on what's going on with your patient as well. Superinfection. Superinfection happens when you're on antibiotic therapy and too many of your host flora are killed, the things that keep, all kinds of things in check, the bacteria that keep all kinds of things in check. So you can get problems like Candida, oral thrush, or Candida in the vaginal area, and that's a yeast infection. Both of those are very uncomfortable and are definitely considered superinfections. Another superinfection, and you may not have known this, is C. diff. And so C. diff happens when we have an immunocompromised patient and we have someone who's been on vigorous antibiotic therapy or extended antibiotic therapy, meaning for a long time. And so as a result, this C. diff bacteria, which is normally kept in check by our gut, is allowed to grow out of control, and that causes severe diarrhea. So in terms of host factors, we have to think about, now, who is the host, right? The host is the patient that the bacteria is growing in. And so we have to think about what's our goal in treating this particular patient, right? And hopefully the goal is to eradicate the infection But it might be that the goal is prophylaxis. We talked about that earlier. We have to look at the place of infection. If you have a place that's like the brain or the bone, those are probably going to be more anaerobic types of bugs versus lungs, which will be more aerobic, right? Just because of the environment that the bacteria likes to live in. Bone is very dense, not very vascular, although there is some vascularity there, and not exposed to oxygen other than what the tissues need. And so typically we see anaerobic types of bacteria. We also want to look at the person's immune system status. Is this a cancer patient or someone else who has a compromised immune system? Is it an infant? Is it someone who's very elderly? We're seeing this in terms of host factors. These are some of the things that are playing a role in COVID-19. And we're seeing patients who are older be more susceptible to that virus. Medications. What kind of medications is the patient on? For instance, if you're taking chemotherapy, again, you are going to be more susceptible to infection because chemotherapy downregulates your immune system. What if you're on immunotherapy for, say, rheumatoid arthritis or ulcerative colitis, and those drugs are doing a great job of controlling your inflammation, but they also put you at higher risk of being immunocompromised. We have to look at age. We just talked about that. We have to look at allergies. You know, penicillin might be the best drug of choice for my infection, but if I'm allergic to penicillin, then all bets are off. It doesn't matter. You can't give this to me because I'll become very, very ill. Pregnancy status. What antibiotics can safely be given during pregnancy? And then race, and this is related to a lack of an enzyme needed to metabolize certain antibiotics. So we know in certain races, certain populations of people do not have the enzymes needed to metabolize these drugs. Now we're going to get into classes of antibiotics. And unfortunately, I have in there chapter 34, and I know that it's chapter 35. And I'm going to try to tell you which page this figure is on, because I think it's really, really good in terms of mechanism of action. Okay, it's 35.5 is the figure. And, 35.1 is the figure, and it is on page 538 in the most recent 5th edition of Pharmacology for Nurses by Adams, Holland, and Urban. So I apologize that one's on there. I need to fix that. So here's our prototypes. We're going to go through them one at a time. Penicillins, okay? Now, always, you have to know what the patient's allergies are. We know that many people are allergic to penicillin. We're going to talk about that a little bit. But penicillin was kind of a common antibiotic. It was the first antibiotic discovered. And so it's still a very good antibiotic and used for a number of things. So it's bactericidal, so it inhibits cell wall synthesis. It has no effect on human cells, and it's used for gram-positive organisms. Now, what I really want you to know is that it's bactericidal more than all the rest of that. I also want you to know, you need to know that it has a beta-lactam ring. Now, back to chemistry. Ooh, this is why you took these things before you came to nursing school. So beta-lactam ring is the structure in the medication that is responsible for its antibacterial activity. Okay, so the beta-lactam ring is also usually sort of the tender point for where resistant microbes like to come in and attack and like restructure themselves so that they're resistant to that beta-lactam ring. However, what's really important is The beta-lactam ring is also what's responsible for most allergic reactions in patients who have allergies to penicillin. Now, many of us can take it and be fine, but the beta-lactam ring is what causes problems. And what you'll note as we move forward is other drugs also have a beta-lactam ring, and thus people who are allergic to penicillin should probably be very carefully taking those other drugs if they take them at all, because there's cross reactivity, cross sensitivity due to the presence of that beta-lactam ring. Side effects can be anaphylaxis. Anaphylaxis meaning throat swells up, hives, low blood pressure, usually, asphyxiated airway of some sort. Could also cause nausea, vomiting, diarrhea. It could also cause a rash. It's best given on an empty stomach. You want to observe for electrolyte balance because almost all penicillins are sodium or potassium salts. And so they have a sodium or potassium salt attached. So if they're on this for a while, it's something that you're going to want to watch in terms of their electrolytes. And then they're often given in combination with other chemicals or drugs. So a really common one, Augmentin, which if you've ever had a sinus infection, you've probably been on this, unless you're allergic to penicillin. Augmentin is penicillin, and it's connected to clavulanic acid, and together that's a more powerful drug. Okay, cephalosporins, and our prototype is cefotaxime. Notice the ceph, right? So cephalosporins all have this ceph name, cefepime, cepha, okay? And they are bactericidal. They too have a beta-lactam ring, which means you do not use these in patients with penicillin allergy due to cross-reaction. And I want to tell you that many times as a nurse, I will see patients ordered these cephalosporins. And you talk to the physician and say, they do have a penicillin allergy. And they'll say, yeah, well, they talked about some nausea, they talked about a rash, but it really didn't sound like anaphylaxis. And so we don't think it's really a real penicillin allergy. And I have to tell you that I always give these drugs with great caution in patients who have a known penicillin allergy. And sure enough, I had a patient who within 5 minutes of getting her cefotaxime was blue, not breathing well, her SATs dropped, we did a rapid response, she ended up going to PICU and being intubated because she had an allergy to penicillin, and yet the doc still wanted to give the cephalosporin despite my questioning him. So never in my career have I been more happy that I had documented that phone call to the physician and that I had documented my concern. There are many generations of this drug. So you will hear, oh, this is a 3rd generation cephalosporin. This is a 4th generation, a 5th generation. And if you remember, back when we started talking about pharmacology early in the semester, we said that future generations tend to have less side effects. They tend to be more specific, and they tend to be more expensive, okay? And so one of the things about later generation antibiotics is they also seem to have less bacterial resistance. So I think we're on to at least 6th generation cephalosporin. We may even be beyond that. Most of these are given IV. A few can be given orally, so you will see a few, but just need to know. And cautious administration in patients with renal or GI disease who are taking diuretics. So we just have to be careful because it can exacerbate renal and GI disease, especially in light of diuretic use. Okay, good old erythromycin. This is a macrolide, and it is bacteriostatic, not bactericidal. So one of the things that you have to remember is that while this inhibits protein synthesis and growth of organisms, it requires good host defenses to eradicate organisms. This would not be your drug of choice in someone who's severely immunocompromised. This drug requires the body's own defenses to do something in addition to the drug doing so. The drug will inhibit protein synthesis and growth of microorganisms, but it's going to take our body's immune system to finish off the job and to actually kill that bacteria and rid it from the system. It needs to be given on an empty stomach, but it often causes GI upset. So they'll say take it on an empty stomach, but then for sure your patient's vomiting. So a lot of times we'll give it with like a glass of milk or something that kind of coats the stomach so that it can make its way into the intestine before it starts causing problems. But some people really can't take erythromycin. It really bugs them. And what's really interesting is this is a drug that's used to treat peptic ulcers caused by H. pylori. And so you wouldn't think that that is really something that we would use since it causes GI upset, but it is the best medication for the H. pylori bug. And it's also a very safe antibiotic. Anaphylaxis is very, very rare with this. Fluoroquinolones. So our prototype is ciprofloxacin, known more commonly as Cipro. Cipro is very broad spectrum. There are at least 4 generations of Cipro. It is bactericidal, so again, kills the cell. And this is a drug that was kind of hot on the market, just like you've been hearing so much about chloroquine, which, by the way, has not been shown to be effective for COVID-19, but people still tout it and use it, which is wrong. People also were using this. People were literally flocking to Mexico when we were concerned about chemical warfare after 2001, after 9/11. And so you have people going down and buying Cipro in Mexico. But this is a drug that not everyone should take, and it's not a drug that you should just take willy-nilly. It can cause crystalluria, meaning crystals in your urine. And so you want to drink at least 8 glasses of water a day and have urine output greater than 1,000 mils or a liter in 24 hours. So this is something that can cause renal damage. It's also contraindicated in children due to tendon issues. It interferes with tendon growth and development, which is something that we don't want to have happen in growing children. And there's many, many interactions. Don't worry about the handout. It was a handout that I had given students in the past, but it's just too much. So don't worry about it. If you just know these basic things about Cipro, you are golden. Okay, aminoglycosides. Gentamicin is the prototype here. And aminoglycosides is something you are really going to want to remember. If you work in any kind of acute care when you graduate, whether it's a med-surg floor, an oncology floor, an ICU, a step down even, you're going to become familiar with aminoglycosides. Now, they are more narrow spectrum. They're bactericidal, but the key thing about aminoglycosides, specifically gentamicin, is it has a narrow therapeutic index, which, if you don't remember what that is, go back and look it up. But we need drug levels. We need a peak and trough around the 3rd dose in order to make sure that our drugs are in the appropriate level. And I'm going to create a little video for you on peak and trough, so we'll talk about that too. It's given IV. It's very poorly absorbed through the GI tract. Now, here is another drug that can cause nephrotoxicity and ototoxicity. Now, nephrotoxicity is reversible, but ototoxicity is not reversible. with these drugs. And one of the things that leads to ototoxicity in this drug and another one we're going to talk about, vancomycin, is rate of administration. How fast you give this drug determines whether or not your patient's going to have ototoxicity. Now, you can also get ototoxicity from long-term use, but far more cases of ototoxicity occur from rate of administration. So these drugs have to be given minimum over 30 minutes. This is used to treat really severe infections such as sepsis, endocarditis, and infections associated with cystic fibrosis. And in fact, you'll note in CF patients that they get higher than normal doses of gentamicin, mostly because their lung tissue is so scarred and so tough and so impermeable from all that scarring that it requires higher doses of gent in order to actually penetrate those tissues and deal with the infection. But we also have to watch their kidneys and their hearing. Tetracycline. So some of you may know about tetracyclines. It's often given for acne treatment. It's broad spectrum. It's bacteriostatic in low doses, but bactericidal in high doses. So that's very interesting. So it's something that you would want to look at if you're giving this medication. It is the drug of choice for Lyme disease or Rocky Mountain spotted fever, which are diseases we don't see a lot of here in California, but on the East Coast, you will see them. It causes permanent tooth discoloration in developing teeth. So do not use in children before the age of 8. And I would have you circle this, star this, something very important to remember about tetracycline. Foods with calcium can reduce absorption, so you wouldn't want to take this with like cheese or milk, that kind of thing. It can also cause pretty significant photosensitivity. So if your patient's going to take a tetracycline, one thing you're going to recommend that they do is to wear long sleeves, a hat, and when they go out, they need to have on sunscreen. Photosensitivity doesn't just mean they'll get a sunburn. It means that the drug actually sort of heightens their skin's sensitivity to the sun, meaning very little sun exposure could cause a really terrible sunburn. And this is a good drug for someone who has a penicillin allergy. It's a good alternative. Vancomycin. So Vanco, I actually, you just talk about Vanco as its own class of medications, but it's called a glycopeptide antibiotic. But most people just talk about Vanco as Vanco. And we know Vanco because it is good for MRSA. And so you see it given quite a bit, especially in the adult population. It is bactericidal. It has extremely high toxicity and a very narrow therapeutic index. So again, you're going to do a peak and trough at least once a week. And again, refer to my little video for peak and trough. It is used only as a last resort for drug-resistant organisms, although it seems like we use it a lot more than a last resort. But I think when you see Vanco, you need to know that you are giving something really powerful that is reserved only for the most serious infections. This too can cause ototoxicity and nephrotoxicity. And even though it is not written on here, you need to write somewhere in your notes that this drug has to be given over a minimum of 1 hour and preferably over 90 minutes. So again, if you give this drug too fast, you're going to see ototoxicity, nephrotoxicity, and the hallmark side effect for vancomycin is red man syndrome. Now, when you're seniors, I should be able to walk up to you and say, tell me what the most significant side effect of vancomycin is. In addition to these two right here, ototoxicity and nephrotoxicity, you should tell me, Dr. Sloan, it can cause red man syndrome. And red man syndrome is this whole series of things that you see together. You'll see flushing, like red. They'll just look red on their face, their cheeks, their neck, everything, like they're blushing. They'll have a rash on their upper body or face, and then they will have hypotension. So now you have red man syndrome. You get to stop your vancomycin. You get to give your patient a bolus, and you get to do some things to try to get their blood pressure back up. It also can cause anaphylaxis, so you have to be extremely careful, and again, look at the patient's allergies. Sulfonamides. So sulfonamides, or sometimes we call them sulfa drugs, these tend to be a class of drugs that a number of people have allergies to, so you have to be really careful with them. But if someone is not allergic to them, then it's a good drug, and it's used for a number of different things. So the prototype is trimethoprim sulfamethoxazole. Sometimes you'll see it listed as SMZ-TMP, or the trade name is Bactrim. Okay, so trimethoprim sulfamethoxazole, or Bactrim, and it's broad spectrum bacteriostatic. Its mechanism of action is it's a folic acid inhibitor. So because it inhibits folic acid, which again is needed for cell division, cell growth, that's how it works in a bacterial cell. It has, unfortunately, we have had a lot of resistance to this drug. And so it's used primarily for treating urinary tract infections and for PCP pneumonia prophylaxis or treatment. Now, PCP is pneumocystis carinii pneumonia. And pneumocystis carinii pneumonia is not something that most of us are familiar with unless you deal with populations that are highly immunocompromised. Transplant patients of any type, kidney, heart, lung, liver, bone marrow transplant. All people who are on chemotherapy, for the most part, are on trimethoprim sulfamethoxazole prophylaxis the entire time they're on chemotherapy, so that we can prevent PCP pneumonia. PCP pneumonia is easily preventable with this drug, but it is very difficult to treat if you get it. And so we prevent it. And patients who are allergic to SMZ, TMP, or Bactrim will go on a different drug called dapsone, which is also prophylactic, but it is used heavily in the oncology population. And they usually take it like 3 times a week, like Monday, Wednesday, Friday, every week, just so that they can keep track of what's going on with their not with their disease, but just keep the PCP pneumonia away. This drug can also cause potentially fatal blood abnormalities. And if you look at these, aplastic anemia, hemolytic anemia, agranulocytosis, those can all be seen using a CBC. So patients who are on this drug should probably have a CBC periodically. Now, if they're a cancer patient, they're going to be having a CBC taken very frequently. But just FYI, sulfonamides are also used as anti-inflammatory, and they can be used as malaria prophylaxis. Unfortunately, they're not used very much as malarial prophylaxis now because of drug resistance, and the malaria has become drug resistant. And then, like I said at the beginning, many, many people are allergic to sulfa drugs, so you really have to watch this. Miscellaneous antibiotics. I don't really care that you know these necessarily. Metronidazole we're going to talk about in another lecture, so it's one that you will get to know. It's used for anaerobes and for H. pylori. When my husband had gut surgery a couple years ago and they took out a big section of his bowel due to diverticulitis, he had so much flagell before, during, and after the procedure. Like, there was nothing left in there. Linezolid or Zyvox can be used for MRSA. That's not responsive to Vanco. And then carbapenems, we aren't really having you learn the carbapenems, but imipenem, meropenem, these are used for serious abdominopelvic infections. So for instance, like somebody with an appendectomy or a peritonitis of some sort. TB treatment, we're just going to do a couple slides on this. But essentially, Mycobacterium tuberculosis is the causative agent. And we know now in the United States that we have several multi-drug resistant strains, which means we have strains of TB that require up to 4 drugs to effectively treat this disease and to eradicate it. It tends to congregate in the lung, and the body builds a little wall around the organism or around that area. It can become like a cavity in there. And then the bug kind of becomes dormant, but it's still alive. And if you're immunocompromised, again, you have AIDS, cancer, anything like that, the infection can be reactivated. So one of the things they'll do before they start someone on chemotherapy or an immunosuppressant drug is they will actually do a TB test. Because if the patient has kind of a latent TB that's sitting in there, not doing much, but still active, we want to know, we want to treat it before we start giving them drugs that are going to wipe out their immune system, which would give that TB a chance to have a major party in there. The bacterium cell wall is resistant to penetration and it requires 6 to 12 months of treatment. Multi-drug resistant TB requires 24 months of therapy. That is 2 years, folks. That is a long time. That's a really long time to be compliant. And I can't even hardly take antibiotics for 10 days, nonetheless, 2 years. So you have to take at least 2, possibly up to 4 drugs needed to treat it. So multi-drug therapy is always recommended now for TB. Using more drugs reduces the development of resistance and increases success. 2 main classes of drugs that we use, and don't worry about this, first line, second line. Prophylaxis may also be needed for close contacts of infected individuals or those who are immunocompromised. So again, if somebody has TB in your home, active TB, you may go on 2 months of prophylaxis just to protect yourself from the bacterium while they're being treated. The regimen that we use is these 3 drugs, NIH, rifampin, and pyrazinamide. And they're given together for the first 2 months of therapy and then tailored to the patient based on what the patient has. And the TB treatment is changing all the time. So it's something that you can go to the CDC if you want to see what current treatments are. All right. Our nursing assessment for TB, again, cultures and sensitivity. We need to know if we have multi-drug resistant TB, what is the form that patient has, what is it sensitive to, and what is it resistant to. We want to watch for superinfection because, again, when we're treating with 2 to 4 drugs, we're going to have patients who get their normal flora wiped out. You want to obtain an accurate history of allergies or hypersensitivity reactions. And then we need to make sure that these patients are having the renal function, immune status, blood counts, all done on a regular basis. And then, of course, watching for fever and watching vital signs. Again, this is something that you can teach families to do at home. Most people, in fact, I know for a fact, all people in San Diego County who have active TB, an actual active case of TB, and there's usually less than 50 in the city, at least, they are all being followed by a public health nurse, and they are all being seen daily to make sure that they take their medication. Again, planning and implementation, monitor for evidence of superinfection. You want to educate the family. Again, like all antibiotics, take all the full course, even if you're feeling better. And I cannot stress that enough in this lecture. People will tell you, oh, gosh, I'm feeling so much better on Thursday, and we started them on Monday, and I know we're supposed to take them 10 days, but I just don't want my child or my family member to have those toxic drugs, so we stopped. Well, that's like the worst thing that they can do, because now that patient is even more susceptible to developing a drug resistant organism. So you definitely want to watch that. You want to monitor drug levels if needed. You want to monitor culture results. You want to monitor for evidence of toxic reactions, anaphylaxis, or worsening of infectious condition. We may identify an antibiotic in the Petri dish that looks like it's going to take care of this bug, but if clinically your patient is getting sicker and sicker, then we need to, try some other things, because it might be that things aren't working. So evaluation should be that there are no signs or symptom of infection, that all of our lab values return to baseline, drug doses are adjusted according to drug levels, the client verbalizes and demonstrates understanding of illness, and there's compliance, meaning they're taking the drug when they're supposed to be taking the drug, so that they can clear. And I can tell you, with parents who are overseeing the drug administration for a child, if they're not compliant and it is a potential life or death thing with the child, this is reportable to CPS, and children will actually be pulled out of the home and given treatment until they need it no longer, and then put back in the home if parents cannot comply with treatment. And I can think of a few cases of a child we had with osteomyelitis whose mom just would not follow up with the very, very important oral antibiotics that she was supposed to take. And the child ended up having a reinfection and lost a significant amount of bone in her tibia, and actually went to the Bernardi Center for the remainder of her treatment because mom had twice could not follow through on the medication compliance. And then we want to make sure that cultures are clear. That is it. All right, guys, thanks for your attention.